The term scoliosis dates back 2,500 years to Hippocrates. It's Greek for lateral curvature.
The side-to-side curvature of the spine.
You can see this lateral curvature on an X-ray taken from the front.
Early onset scoliosis is the initiation of a significant spinal deformity in a very young child.
That begins or becomes a problem usually prior to 3 to 5 years of age.
Many of the real, true early onset scoliosis children that approach us are infants and toddlers.
The incidence of regular or all-comer scoliosis is about 1 in 1,000. For early onset scoliosis, it's much less common than that, maybe 1 in 100,000. So they're very rare disorders.
Most scoliosis being the teenage type, which we term idiopathic adolescent scoliosis. But the early onset scoliosis is much more severe and can cause more problems with pulmonary disease later in life.
There are patients with chest wall deformity, and that may or may not be syndromic, and those patients will have different issues or problems to address. Some of the patients have malformations of vertebra.
What's called failure formation, failure segmentation. This is looking just at the spine, but this translates also to a chest problem. So if you have missing ribs, you have failure or formation. Ribs that are fused, that part of the spine is usually fused adjacent to it. That's failure segmentation. You can have a birth defect where the thorax is too narrow. That's also a volume depletion deformity, the most common being June's asphyxiating thoracic dystrophy.
The complexity can be as simple as you got a 10-degree curve to something significant. You have a 100-degree curve and your lung doesn't move on the left side.
Early curvature of the spine is a simple spine problem. Once the deformity progresses and starts to warp the chest, then it starts to provoke early thoracic insufficiency syndrome.
Thoracic insufficiency is the lack of enough pulmonary function or lung function to support the patient.
The inability of the thorax, which is the spine, rib cage, and the breathing muscles, to support normal respiration or lung growth.
So the patients have difficulty breathing and functioning in a normal way.
Many of the patients already are well into thoracic insufficiency and need support. Others are clearly headed that way.
So the chest may do justice to lung growth the first year or so, but gradually the lack of growth is a serious, irreversible problem. You look at an X-ray and your spine is curved like this, but to look down inside the child, the thorax looks like a big oval, and then as the spine curves, it shifts, but it shifts into the chest, and it starts to push on the lungs, leaving it no room, and then the rib cage on the side, the spine rotates into, stops moving. So you not only lose volume, you also lose the chest's ability to aid respiration. And once we understand it better and pioneer treatments to reverse it and pull it out to normal shape, normal volume, and normal function, then we'll have much better treatment for these children with early onset scoliosis and thoracic insufficiency syndrome.